Hi everyone. Today I am discussing about the topic toxic goiter. See, in this picture also we can see the difference between the normal thyroid and enlarged thyroid gland. Normal thyroid gland usually weighs about 25 grams, but in case of enlarged thyroid gland, it becomes quite big in size and nodular in shape also. And coming to the terms which involved in the toxic goiter, they are hyperthyroidism and thyrotoxicosis. Hyperthyroidism means increased secretion of active thyroid hormones from the thyroid gland, but in case of thyrotoxicosis, there is excessive or abnormal secretion of thyroid hormones in spite of irrespective of the source. And see the difference between the thyrotoxicosis and hyperthyroidism. There is excessive secretion of the thyroid hormones irrespective of the source. In case of hyperthyroidism, there is secretion of thyroid hormones mainly from the thyroid gland only. And coming to the types of toxic goiters, there are usually two types. They are primary thyrotoxicosis and secondary thyrotoxicosis. The primary thyrotoxicosis usually occurs in younger patients, and which is mainly due to thyroid pathology, which leads to heavy abnormal secretion of thyroid hormones in the body. Then goiter symptoms occur along with the toxic symptoms. Central nervous system is usually dominantly affected, and symptoms appear very suddenly. And exophthalmos and several eye signs are also usually common. And these goiters is usually affect the females than the males. The usual ratio is about 6:1, and the goiter is uh, normal in size. And in case of secondary thyrotoxicosis, which is mainly due to increased secretion of thyroid stimulating hormones in the body, then which is usually seen in the middle-aged people, that is above 35 years age patients. And goiter appears first, then after toxic symptoms appear. Females are mostly affected than the males. Ratio is about 8:1. And cardiovascular system is usually affected, and exophthalmos and eye signs are virtually never seen. And the goiter is usually uniform and nodular and quite big in size. And coming to the causes of toxic goiter, they are Graves' disease, toxic multinodular goiter, toxic adenoma, D. Quervian thyroiditis, struma ovary, thyrotoxicosis factitia, Jod-Basedow syndrome. And we can discuss about each of these diseases. Firstly, Graves' disease. What is this Graves' disease? It is a diffuse goiter of the functioning of the thyroid gland, which causes hypertrophy and hyperplasia, which leads to the increased secretion of thyroid hormones by some of the stimulators like LATs, long acting thyroid stimulator. Normally, the thyroid stimulating hormone is is stimulated by the anterior pituitary from the thyroid gland, which is usually binds to the uh, thyroid gland, which is stimulated by the adenylyl cyclase to produce thyroxine and triiodothyronine. But in case of person with Graves' disease, which makes the autoantibodies, which attaches to the TSH receptors, then mimics with the TSH receptors action without regulation, which leads to the overstimulation of the antibodies, overstimulation of the thyroid hormones. So these autoantibodies are all called as LATs, that is long acting thyroid stimulators. And coming to the another condition, toxic multinodular goiter. This is also called as plumber's disease. In this multinodular goiter, these each nodule acts independently, which continuously producing the thyroid hormone, which leads to the enlargement of the thyroid gland. And coming to the another condition, toxic adenoma. This is usually a benign adenoma, which is also called as toxic solitary nodule. This solitary nodule continuously producing thyroid hormone, which leads to the increased size of the thyroid gland. The common treatment for this toxic adenoma is the surgical removal. Another condition is dequervain thyroiditis. This usually includes viral infection. This causes neck pain, tenderness, dysphagia, fever, and hyperthyroidism. Due to this fever, the thyroid gland becomes increased circulation of the thyroid hormones, which leads to neck pain and tenderness, dysphagia. This hyperthyroidism includes two phases: hyperthyroid phase, then it becomes followed by hypothyroid phase, then the thyroid becomes normal level after testing, and which is a self-limiting disease. And some supportive care includes fever is treated by the NSAIDs, and hyperthyroidism is treated by the beta blockers. Then coming to the thyroid storm. This is also called as thyrotoxic crisis, which is a rare presentation of the hyperthyroidism and acute severe presentation of thyrotoxicosis, which includes pyrexia, delirium, and tachycardia. So the patient is admission for the monitoring and some of the supportive care, which includes fluid resuscitation and antiarrhythmic drugs also given to the patient. And some of the clinical features of the Graves disease. Mostly the universal features of Graves disease, which includes insomnia, emotional instability, restlessness, weight loss, in spite of increased appetite also, tremors of the extended and abducted fingers, hyperactive tendon reflexes, intolerance to heat, and increased sweating, erythemia. Okay, and some of the gastrointestinal disorders like diarrhea and increased frequency of defecation and increased bone turnover, which causes hypercalcemia. And mainly the Graves disease, which is an autoimmune disease, which includes conditions like hyperthyroidism, and that is goiter and exophthalmos, and skin conditions like pretibial myxedema. Uh, in case of skin, the changes in skin like appendages like warm and moist skin, facial flushing, precipitation, soft and fragile nails, fine and easily falling hair, gynecomastia, menstrual irregularities, and increased libido but decreased fertility. And skin condition, another one is pretibial myxedema, which is a thickening of the skin with mucin like deposit in the lower part of the leg. And another one is exophthalmos. Exophthalmos, the eye signs of the Graves disease, which is the retraction of the eyelid, spasm of the upper eyelid with lid retraction, and proptosis with widening of the palpebral fissures, and supraorbital and infraorbital swelling, and congestion, edema, and chemosis of the conjunctiva, papilla edema, and corneal ulceration also takes place due to the eyelid retraction. And some of the various other eye signs also occur in thyrotoxicosis. They are usually von Graf sign. When patient is asked to look down, his upper eyelid fails to follow the rotation of the eyeball and thus lags behind. And another sign, Rosenbach sign, tremors on closing eyelids. Stellwag sign, staring look with infrequent blinking. And Joffre's sign, when the patient is asked to look upwards with the head fixed, there will be absence of wrinkling on the forehead. And Mobius sign, lack of convergence due to ocular myopathy. And this is called as exophthalmometer. This is usually used for the extent of exophthalmos, or proptosis can be measured with an exophthalmometer. And some of the diagnostic index like Venice index, which is used for the signs and symptoms of the thyrotoxicosis. There is a numbering given. The usual symptoms involved are palpable thyroid, exophthalmos, lid reaction, finger tremor, brute over thyroid, atrial fibrillation, pulse rate more than 80 per minute. And symptoms which include palpitations and excessive sweating, appetite increased, appetite decreased, weight decreased. So the index is over 19 indicates toxic goiter, which is below 11 which indicates non-toxic goiter. And coming to the management, there are usually the three main approaches: antithyroid drugs, radioactive iodine, and surgery. Firstly, antithyroid drugs. Usually, the first line of drugs are carbimazole, and second line of drugs are propylthiouracil. Due to this propylthiouracil, more complications like death and coma. So, most commonly used drug is carbimazole, and this decreases the formation of thyroid hormones by interfering with the organic bonding of iodine or inhibiting the coupling of iodothyronine. So, zero point 0.2 micrograms of thyroxine is given additionally to minimize the size of the goiter quickly and to counteract any changes of iatrogenic thyroid insufficiency. And another one is radioactive iodine. This radioactive iodine usually destroys the thyroid cells and reduces the mass of functioning thyroid tissue, and which is not advised in pregnant women, nursing mothers, and also avoided in younger patients due to genetic damage, leukemia, and subsequent development of carcinoma, which is usually indicated for the adults above 40 years of age. And another treatment is the surgery, thyroidectomy. It is the treatment of choice in case of big diffuse goiter and toxic nodular goiter. And some of the complications of thyroidectomy, they are immediate and late complications. Immediate complications are hemorrhage, infection, recurrent laryngeal nerve palsy, thyroid crisis or storm, respiratory obstruction, parathyroid insufficiency. That is called as tetany. And late complications are thyroid insufficiency, recurrent thyrotoxicosis, progressive exophthalmosis, and hypertrophic or keloid scar. And coming to the recurrent laryngeal nerve paralysis, which is usually temporary and is caused by the pressure from the hematoma or edema, and it usually recovers in 3 weeks to 3 months time. Beyond this, permanent injury to the nerve should be suspected. After that, in case of bilateral involvement of the recurrent laryngeal nerve paralysis, the vocal cords will be motionless, lying in a cadaveric position. Immediate tracheostomy is the life-saving measure. And another one is thyroid crisis, which is also severe thyrotoxic reaction that appears suddenly within 3 to 4 days after operation. And respiratory obstruction, which is mainly due to laryngeal edema. Endotracheal should be left in place for several days and steroids should be administered. And damage to the parathyroid glands, which leads to the tetany, which usually present within 2 to 5 days after operation, but a few many delayed for 2 to 3 weeks. It can be recovered spontaneously. And thyroid insufficiency is the most common complication following thyroid surgery. It is usually appears within 2 years and may be delayed for 5 years or more. And keloid scar can be avoided by incising the platysma at the level just above the skin incision. So these are the treatment measures also, and complications. Thank you. The next topic is tumors of the thyroid.